Every second of your life, a high-pressure vascular highway rushes oxygenated blood from your heart to the furthest reaches of your body. But this delivery system can fail. Sometimes the pipes silently narrow over decades of wear. Other times, a sudden, catastrophic blockage halts all circulation in a matter of hours. Missing the clinical warning signs carries heavy consequences: chronic, debilitating pain, irreversible tissue death, major amputations, or fatal internal ruptures. To save limbs and lives, surgeons have to intercept arterial failure. We can break these interventions down into 4 distinct, escalating clinical stages: chronic disease, acute emergencies, gangrene, and aneurysmal structural failure. The first stage is a slow starvation. Over years, atherosclerotic plaque, a sticky mix of fat and cholesterol, builds up along the vessel walls, gradually choking off the space for blood to move. The clinical hallmark of this narrowing is intermittent claudication. Patients experience a severe, cramp-like muscle pain brought on strictly by walking, which reliably disappears after resting for about 5 minutes. The term claudication actually comes from the Latin word for limping. It's a direct reference to the Roman Emperor Claudius, who was historically known for walking with an irregular gait. This angiogram shows a blockage higher up in the large iliac arteries. This causes Lericia syndrome, severe buttock claudication, and impotence. Notice the twisting, spike-like vessels branching off. The body is attempting to survive the blockage by routing blood through smaller alternative paths. Eventually, the disease can overwhelm these natural backups. The progression reaches an end stage, known as chronic limb-threatening ischemia. The legs turn pale, and the patient suffers agonizing pain even while resting in bed at night. Chronic disease is a war of attrition. Without a surgical bypass or a stent to prop the artery open, the slow starvation will eventually claim the limb. Contrast that slow buildup with an acute occlusion. Here, a sudden embolus, a rogue clot dislodged from an irregular heartbeat, travels down a previously healthy artery and wedges tight, instantly halting all forward flow. Because there was no time for the body to build backup vessels, the limb goes into shock. Clinicians diagnose this emergency by looking for the 5 Ps: pain, pallor, pulselessness, paresthesia, and paralysis. Paralysis is the most critical sign. It means the limb is completely insensate, triggering a strictly limited 6-hour surgical window before tissue damage becomes irreversible. The immediate medical response is a rapid infusion of intravenous heparin. This prevents the clot from growing and propagating further down the stagnant leg. But the definitive cure requires physically dragging the clot out. Surgeons thread a deflated Fogarty balloon catheter past the blockage, inflate it, and forcefully pull the obstructing mass backward out of the body. When successful, the physical evidence extracted from the artery looks like this. Unlike chronic disease, an acute strike leaves no time for adaptation. It requires immediate, aggressive physical extraction to reverse the sudden oxygen starvation. If flow cannot be restored, the biological outcome is gangrene. Large sections of tissue simply die, turning black as hemoglobin breaks down into iron sulfide. If the loss of flow was gradual, the tissue desiccates, forming dry gangrene with a sharp line of demarcation. But if bacteria infiltrate the dead tissue, it putrefies, creating the rapid, aggressive spread of wet gangrene. This clinical image shows severe wet gangrene on a toe, illustrating the reality of superadded infection and profound tissue necrosis. This threat is magnified in diabetic patients due to a uniquely dangerous triad. Narrowed arteries limit the blood supply, neuropathy prevents the patient from feeling the initial injury, and high tissue sugar creates an ideal environment for bacteria to multiply. When the limb is heavily infected or devoid of pulses, surgeons have to determine the amputation level. They fight to keep the cut below the knee whenever possible, as preserving that single joint drastically improves a patient's ability to use a prosthetic. In these final stages, a major amputation serves as a defensive salvage operation, halting systemic infection before it can claim the rest of the patient. But flow blockages are only half the story. Arteries also face a structural threat, an expanding weakness in the vessel wall itself. In an abdominal aortic aneurysm, the main artery descending from the heart begins to silently balloon outward. Subjected to continuous, rhythmic high blood pressure, the wall thins and stretches over time, creating a hidden ticking time bomb. Rather than opening the abdomen to stitch in a replacement tube, modern surgeons often rely on endovascular aneurysm repair. They use a device like this, a synthetic fabric graft supported by a metallic wire anchor system. On the left of this CT scan, we see the massive, swollen aorta expanded past its safe limits. On the right, the deployed stent graft bridges the gap from the inside. It creates a reinforced channel that completely bypasses the weakened outer walls. Aneurysms represent a structural failure. By deploying these grafts through the arteries of the groin, surgeons can reinforce the plumbing from within, neutralizing the threat before the vessel bursts. The vascular network is a high-pressure delivery system, yet it remains vulnerable. While it faces threats ranging from slow clogs to sudden embolic strikes and bursting walls, we are no longer helpless in the face of these failures. Recognizing the clinical warning signs, like the 5 Ps of a sudden clot or the simple muscle cramp of claudication, provides the head start medical teams need to intervene. Today, modern vascular surgery has moved far beyond a primary reliance on radical amputations. By utilizing tools like balloons, stents, and bypasses to restore circulation, surgeons can now save limbs and lives that were once considered lost.